Welcome, everyone, to the annual Department of Kinesiology Pease Scholar Lecture. My name is Phil Martin. I'm the chair of the Department of Kinesiology, and I'm very pleased to be able to introduce our speaker tonight. The Pease Family Scholar Lecture is one of the highlights of the year for the department every year. This is the 16th lecture in the Pease Scholar Lecture series. We're here tonight related to the Pease family. We're here tonight because of the generosity of Dean and Sally Pease and their lasting commitment to the Department of Kinesiology and to the university. Dean Pease was a longtime faculty member in the department and a former department chair. And he and his wife, Sally, before Dean's untimely death, established an endowment in memory of Dean's parents. And this endowment supports 3 different programs in the department, one of which, and the major component of their support, is for this particular activity, the Pease Family Scholar activities. We refer to this as a scholar in residence. And so this endowment that the Pease family established allows us to bring someone in every year and share their expertise with faculty and students in the department. When we bring someone in, we always try to create opportunities for not only faculty to interact with our guests, but also our graduate students and undergraduate students. And we've had a very good day in that regard, I think. So we've kicked off these 2 days of Dr. Sugden's visit very well, I think. So I'm pleased to introduce this year's Pease Family Scholar, Dr. David A. Sugden. He's a professor of special needs in the School of Education at the University of Leeds in the United Kingdom. He received his diploma of Loughborough Colleges in 1966. Loughborough is pretty well known. If you're from our field for very long, you've heard of Loughborough. But then he came over to the States, went to UCLA, received a BS, MS, and PhD in 1970, 72, and 77, respectively. And what he did in his academic preparation is build an interdisciplinary foundation that blends developmental psychology, special education, and physical education. In addition to his university scholar activities, Dr. Sugden's professional experiences include teaching in primary, secondary, and special schools. So he had that hands-on experience in the schools. And he began his appointment at the University of Leeds in 1977, where he quickly advanced through the academic ranks. He also has provided considerable leadership at the University of Leeds, starting first as a chair of the School of Education, then dean or acting dean of 3 different faculties, which is equivalent to our colleges, and then most recently as vice chancellor at the University of Leeds, which is equivalent to our president. It'd be the same as President Joffrey. He'd be the chief operating officer, so to speak, of the university. Despite these many contributions to leadership, Dr. Sugden has managed to maintain a very productive research career during his 30-plus years at Leeds. And over his career, Dr. Sugden's research is focused on 2 primary areas: experimental and field studies of children with motor disorders, cerebral palsy and developmental coordination disorder, and special education needs of children, especially related to developmental disorders and general learning disabilities or difficulties. We're going to hear mostly about the first of those areas, I think, tonight. That's what links to us most closely. Much of his research has addressed the acquisition or the performance of motor skills in children with and without disabilities. He notes that much of his work is quasi-experimental, working with children and involving tight, small-scale projects. Other research concerns hand functions in children with hemiplegic cerebral palsy, involves the use of biomechanical techniques to examine practical therapeutic intervention techniques, and incorporates theoretical motor control and developmental issues such as dynamical systems and neuronal selection. Dr. Sugden describes his current research activities as being of a more practical or translational nature, examining the assessment, classification, and intervention of children with developmental coordination disorder. This involves working with educators, health professionals such as OTs and PTs, and family members as well. Dr. Sugden has authored more than 60 research articles, 30 book chapters, 9 books, and has received funding to support his research from numerous funding agencies over the course of his career. He has also been an invited or keynote speaker at national and international conferences more than 40 times. So obviously, Dr. Sugden is very accomplished and is highly regarded by his colleagues for his expertise related to motor and developmental coordination disorders in children. So it's my great pleasure to introduce Dr. David A. Sugden as the 2010-11 Pease Family Scholar. Dr. Sugden's presentation tonight is entitled Identifying, Assessing, and Supporting Children with Movement Difficulties. Please help me welcome Dr. Sugden.
Thank you very much. Is this on? Yep. Yes, good. First of all, can I thank the Pease family for the honor of inviting me. It was just such an honor to get this invitation and great privilege to come here. I've never been to IO before, and it's been a wonderful first day. I apologize for the British weather I brought with me tonight. That seems to have followed me around. It followed me into, I was first of all in California, as Phil has just said. I was at UCLA for 5 wonderful years, and my wife is Californian and my children are dual nationals. They come into the States on American visas and go out on British visas. They never get in queues, in lines at the immigration, so they do that. But thank Phil and the department for the lovely reception I've had. I've had dinner at Aunt Maud's, which was a treat last night, and it's been lovely today, talking with students and staff today. So my passion for a number of years has been children with movement disorders, and that's what I want to talk about tonight. It's interesting, I'm in a school of education, and but I draw upon multidisciplinary activities from pediatrics, from psychology, from health sciences, teachers, and so they tend to come to my classes. My bread and butter, how I pay for myself, is by teaching courses on autism and attention deficit and dyslexia, speech and language disorders, cerebral palsy, etc. But my passion is for children with movement difficulties, and I don't think I need to preach to the converted by saying, if you think movement's not important, just think what you've done today that's not movement. And there's not a lot. And I think thinking's about it. That's it. So movement is so fundamental to us, and so when children don't move very well, we need to look at that. The talk is going to be split into 3 areas. One, I'm going to talk about who are these children. And secondly, describe the work in a global fashion of what we've done over the last 15 years. I spent 15 years doing theoretical and empirical work, and then I decided, no, I'm going to do some intervention with children. When we started looking at what are the best ways of teaching these children to deal with difficulties. I'll put this down so I can glance at where I am in relation to time. So that is my passion. And the third area, I'll just give a brief outline of a study that we conducted not too long ago. And so no, that's not it. There we go. There we are. So, who are the children? There are 2 types of children. You can broadly categorize them into 2 groups of children. There are those children who have movement as their primary defining condition. And I'll talk a little bit about those. And then secondly, there are groups of children who have another defining condition. They have they're diagnosed in a different way, but they all have movement as a secondary characteristic. And so I'll briefly just take you through those. So the primary condition, the most common one, which is worldwide, doesn't matter what culture you are in, is cerebral palsy. The most recognized and prevalent constitutional, in other words, we know what's there, condition that has motor difficulties at its core. absolutely worldwide. And the prevalence of this condition has not changed in 30 years. It's 2 to 3 per 1,000 in developed nations. Prevalence rates in non-developed nations will be higher because of the issues surrounding medical care during the birth, the gestational and birth period. So, why hasn't it changed? Well, basically because we are saving babies who are smaller and who are a smaller birth weight and a shorter gestational period. So we're saving babies at 23, 24 weeks now, whereas 15 years ago this was highly unlikely. We're just involved with a study at Stanford University where they're using a test I've developed for 550 premature babies below 27 weeks in gestation, and they're below their mean weight is 800 grams. So these are tiny babies. These are 2-pound babies. So they're tiny. So there is a cost with this, of course, as many of these babies develop various forms of disorders, and one of them is cerebral palsy. Cerebral palsy is quite... So the incidence or the prevalence of cerebral palsy in that kind of cohort will bring up the overall prevalence in cerebral palsy as a whole. So that's why it hasn't changed in 30 years. It's because we're saving more babies, but again, at a cost. Diagnosis is by degree of difficulty, whether it's mild, moderate, severe, by location, whether you are diplegic, legs only, or more legs, whether you're hemiplegic, split down the side. You've often seen children who have one side that is impaired, quadriplegic, tetraplegic, unusual, that's three limbs, or monoplegic, again, unusual. But diplegic, hemiplegic, and quadriplegic are the ones that I'm sure you're familiar with. And then by type of movement difficulty, whether it is a spastic movement, which is that very tight clonus where there's the antagonist and agonist muscles working at the same time, and then all of a sudden there's a release of it, and you get that jerky kind of movement, so they're reach and grasp. And then there's dystonic movements, which are that child who just can't stop, and the child is writhing all the time. Very small minority of what we call ataxic, and this is a cerebellar dysfunction as opposed to a pure cortical. And these kiddies, if you go into a school, they often wear crash helmets because they're falling over all the time, and they have a stumbling gait. And so, that is the most recognized prevalent constitutional disorder. And I've worked a lot with those children, a lot of the work, and we're going to talk a bit more about these children later on. Developmental coordination disorder, often called dyspraxia, used to be called clumsy, but now DCD is internationally, worldwide accepted. And those of you who know the APA, which is the American Psychiatric Association, will look at, they have clear definitions of what this is. And we've got to get that so that we know when we have a cohort of children that we're measuring the same children, that we're across countries. And we started an international conference in 1993 in London, and in 2009, as Anne will say, we had was it the 8th or 9th? 8th, I think it was. The 8th one in Baltimore. First time we'd had it in the States. And so it is starting to get big publicity in the States on that. Prevalence depends on cut-off criteria. Prevalence always depends on cut-off criteria. If I say everybody in this room is not very bright, if you have an IQ below 170, some of you may be okay. I wouldn't be, but some of you may be okay. So prevalence is where you cut you have to have a reason for that. The definition includes 4 criteria, which I won't go into now, but it's basically that the movement difficulties are significant and have a negative effect on activities of daily living or academic performance. So those are the children we know with the movement defines their condition. However, we always have children who have some other defining condition, And as a group, they will always show a higher prevalence. I don't care whether you take autism, dyslexia, attention deficit, speech and language impairment, whether you take any of those or just generic learning difficulties, you will get a higher prevalence of motor difficulties in that population. Absolutely, worldwide that happens. Why is that? Well, it could be because the biology of the child says it's not just affecting that particular one attribute, that ability. Might be cognitive. You know, many of our motor tasks are cognitive. You know, when I catch a ball, I have to know something as well as do something. You know, I have to be able to predict, anticipate, and do all of those good things as well as just stick my hand there and catch it. You know, I have to watch it, view it, make all kinds of decisions on that. It may be task and behavioral oriented. That the kind of task we give children are complex, you know, that demand different kinds of attributes. And therefore, we always get this higher rate of prevalence in children with difficulties. It doesn't matter whether you go, and you go to any of these. So intellectual disabilities, and I don't care whether you're talking about a general learning intellectual disability or whether you're talking specific, such as in dyslexia. Whether you're talking about sensory difficulties, vision, there's the obvious one. You know, visual people have, with vision you have difficulty with movement because A, they have difficulty in near space, reaching out for things that are near them, and then they have difficulty in traveling space, moving around the environment. And there's huge amounts of work done on how you can transfer the attribute of such as hearing to augment the lack of vision. And what happens, you know, just crossing a road, for example. How far is that car away that is coming? Have I got time to walk across the road? And we know things like hills and bends, they distort the audition, and so it is difficult. Hearing, more complex. But those of you, you know, we do know about the vestibular mechanisms that have problems with balance, with children with balance. But in a more practical situation, play a game like handball or racquetball and try playing with earphones on. It's not easy. You depend upon hearing a lot more than you think you do. Specific social emotion behavioral difficulties, in general, if you could test them properly, they probably don't have a higher prevalence. But because you can't test them properly, because they're usually uncooperative, then you get, again, a higher prevalence in that. So functionally, you get a higher prevalence, even though fundamentally, structurally, there may not be any real reason why they should be. But when you get into autistic spectrum disorder, clearly is a characteristic which goes from classic autism, who have quite severe problems, to those with Asperger's who have a different, higher function in terms of intelligence and language, but still have motor problems. 60% of your children with DCD would also fit into the definition of ADHD. We have just got a stack of evidence on that. And that's, you know, it's kind of obvious. You know, if I've got an attention problem, I'm going to have difficulty moving on that. And speech and language impairment, similarly. So these are all kiddies who have problems in movement, even though their defining condition is something else. So one of the things we first ask is the movement difficulty causing distress? You know, because some kiddies, you know, okay, although I say movement is fundamental to life, some things, I'm okay, I don't need to do that. But most of the time, is it preventing reasonable access to activities of daily living? Would the young person's life be improved by increasing movement skill? Are relevant individuals prepared to work at it? There is no substitute for working on this. It is tough going for some children. So we call it ecological intervention. And what we say is, you've got three keys to this. You've got the resources of the child. What does the child bring to the situation? You've then got to say, okay, what is the environment like that the child performs this? Because, for example, if I just say, and I'll do this a bit more detail, but if I've got a school district that is very supportive of children with cerebral palsy and movement difficulties, and I've spent a lot of money on occupational therapists and physiotherapists, physical therapists in this country, is physiotherapists in England, then that's going to be, the outcomes are going to be a lot different to an authority that doesn't spend money in that way. It's clear. And then this bit here, how do you present those tasks? How do you teach them? How do you coach them? How do you use therapy? And so the problems, and this has got to be the take-home message to you, don't reside in the child. Some of them do, but we can influence these. And that's why we call it ecological intervention, because we can influence those things. And this is the model I've been working to with various kinds of field studies and empirical studies over the last 15 years. So EI is a way of thinking. It's not a rigid package that must be delivered in a specific way by professionals. It might include that, but that is not its sole way. A starting point is that intervention cannot be viewed as an add-on to daily life. It should be an integral part of daily life. You know, your once-a-week therapy, no matter how good you are as a therapist, ain't going to be enough. And I've said it a couple of times today, you know, once a week for an hour, it's like that diet, doing it on a Thursday afternoon. It ain't going to do it. You know, there's another 6.5 days you've got to deal with on that diet. And the other thing is that different individuals play different roles, but equally important. The child, we are massive proponents of listening to the child's views. As soon as the child can have a view, we don't always agree with them, and we have to do a little bit of kidology with them, but we do listen to their views. Parents, health visitors, professionals, and others. So, these are not kind of bouncing slides, by the way. They're fairly straightforward slides. They don't have big pictures all over the place. We have two things to get people to move better. One is you've got to get participation. If you don't get participation, you cannot get improvement. Absolutely, full stop. That's dead. And secondly then, successful learning through good teaching or good therapy. And I always ask people, what's the difference between good teaching and good therapy? And I'm not quite sure what the answer is. It's an interesting question, because we're basically getting successful learning. And if you're a therapist, you call it therapy. If you're a teacher, you call it teaching. I suppose that's where my where it ends on that. So, and there may be different variables that will. There are different variables that affects that to that. So, we call it ecological intervention. We have 4 parts to it. Recognize a difficulty, collecting information to plan the program. Notice we don't call it assessing and diagnosis. We collect information. And that includes assessing and diagnosis. And then we plan the program, and then we implement the program. So, recognizing a difficulty, that's easy. Someone has suggested there's a problem. Can be parent, family member, teacher, friend, child, him or herself, and somebody then takes a decision to investigate. It's as simple as that. Someone has said, this is important enough, and I'm not qualified to say whether it is important enough, but somebody is saying, this is distressing to the child or the family or those around them. So we then do the first part of our triangle, which is collecting information on the child. We say, okay, and we collect a whole, look at all this stuff. We try to get this. You never get all of this stuff, but you can get as much as you can. So we have standardized tests, which is the Movement ABC, the Bruninks, the early years. This one is by far the best. We did that one, in case. But no, they're all good tests, all good tests. And we then dynamic observation by skilled OTPT. You know, what do they see when they're assessing the child? Write the notes down, not just the results of the test. Criterion reference test, checklists from teachers, parents, and others, interviews with the child, with the teachers, with the parents, school reports. This is DCD, and that's why I've put exclusionary criteria, because there's under APA definitions of what DCD is. It cannot be cerebral palsy, and it cannot be mental retardation. So that's what C and D is. And then what are the other things, you know, that... so I've got a child who has no problem with attention, is a pretty resilient child and is keen, enthusiastic, and poor motor skills. And I've got a child who is fairly fragile and has got low attention, but the same motor skills. Two different animals altogether. And your intervention will absolutely be geared looking at these as well as their motor characteristics. You can't give them the same program on that. So you collect those resources on the child, and that's the top of our triangle. So then, and we then build a profile, we set a number of objectives, and we set priorities. A side issue here is when we set the objectives, we did a little study where we asked the parents what they wanted from the program, and we asked the teachers, and the parents said, oh, we'd like them to be better coordinated. And the teachers said, we'd like them to be better coordinated and organised. And then we asked the kids, and they said, I want to ride my bike. I want to write faster. And I want to be able to get changed in PE so I'm not the last all the time. They were very specific about what they wanted to do. And so we teach those functional skills. That's what we may not be curing whatever the child's got, but the child is a much more competent human being when we've taught those particular functional skills through our various programs. Priorities, you know, how do you set priorities? Well, you know, they come from a side, what's the one that causes most problems? This is the one we love. Can we get a quick win? You know, is the one that's dead easy? Do you use that term, dead easy? I don't know if you do. But is the one that's really easy that makes the child just feel better about themselves? And that you get a carryover into all kinds of things from that. So this is how we sometimes talk to the child about what they want. We get 3 objectives. And if they've got 3 and we've got 3 different ones, we usually negotiate so they get one of the 3. You know, you've got a little bit of horse trading to do with the child. It depends how old they are on this. But they should involve the child at all times. Child, you know, in the university, if you're faculty, if you're students, if you're involved in the decision-making process, you're much more likely to comply with that. Even if you don't agree with what's happened. If somebody's consulted you, it's nearly a first rule of management on that. And it's no different with children. So our second part of the triangle is to say, okay, we need to collect information about the environmental context because that says, how do we get participation? That tells us how we get participation. How can we organise? So we need to look at the family and home, the school setting, the health service, the community. And I apologise because this may not translate directly, but family and home, you know, what are the daily life and routines of the family? What are the family circumstances? We're not prying into their circumstances, but we need to know, have they any spare time? Have they a garden? Are they in a high-rise flat? You know, what kind of opportunities are there? What are the cultural values? Leeds is a fantastically multi-ethnic society. We have just, you know, it's New York in the 1920s is Leeds, you know, in terms of you know, a pooling of people from everywhere in the world. It is a big city, we call it big, it's 750,000, and it is, and so we have to take into account the cultural values of that family. And there's a lot of work done by people in the States that says you've really got to give information so the family can make informed decisions. You know, you've got to empower the family. And if you don't do that with any child with not just a movement difficulty, but with any special educational need, I think you're doomed. I really do. I just don't think you've got a hope. If all you're doing is one session a week somewhere and it's divorced from what's going on in the culture and family, it's not going to happen. So this is why, you know, we just need this family on board, and we work just an awful lot with families. School setting, I don't know what you've got here, but this, there's always a school policy on special educational needs, but then we go in and say, well, what actually happens? Everybody's got a school policy that's really good, it looks brilliant. You go in and nothing's happening, and I'm sure it doesn't happen in Iowa, but it does in Leeds. They have a brilliant policy. You go in and say, where's all this gone? And there's nothing happening. So we have to see what is happening, what help can be given in the school. So we're looking at what help can be given in the family to engage participation, what help can be given in the school, what support practices are available. We have things called statements, which is a legal definition of a child with quite severe special educational needs, and any child with a statement gets a bag of money on their back that goes to school with them. Well, not literally, but it follows them to school so they can get support practices. And I'm sure there's similar things happening here on that. So we need to know that. Here we go. What part of the OTs and PTs, one of my favourite topics, what is the mode of delivery, and we've been talking about that today. Are there waiting lists? When we did work on a study I'll show you later on, there were 200 on a waiting list in Leeds with a diagnosis and nothing happening. The kids are going to grow up, get married, have kids before they get anything. So we got some money from the medical people to try and take some of them and say, can we provide a model that helps them, that takes them off? Because it just wasn't happening on a one-to-one basis. An OT or PT going into schools and working with this child one-to-one. It wasn't happening. So we had to think of an alternative model. GP, do you call them general practitioner? Yeah. I mean, what do they know? Well, not a lot usually. But they usually refer you to a pediatrician or a pediatric neurologist or an OT and PT. So you've got to see what help is available and how is that structured as well. And then the next one, what is the community like? Is there sport for kiddies with disabilities? Not just obvious disabilities like cerebral palsy and wheelchair kind of action, but is there support for kiddies who are that moderate problem of coordination? They don't have cerebral palsy, but they're last to get changed. Their handwriting's appalling. They never get picked in any games. They're clumsy. They don't ride a bike, and it is very distressing for them. It's very distressing for them. So is there any support within the community for this kind of child? So that takes us, all of that now says I've got my resources of the child, I've got my my environmental context, and by moderating the environmental context I can moderate how much participation is being done. And this is what we've started doing. And now, okay, so then we say, I've got this child in front of me, or I'm now going to deliver the program. What do? We have seven pieces of guidance. We call something the movement coach. We like this because I don't know what it's like here, but a child goes to an MD, a GP, and the child has got something wrong. They don't know what it is. They come out with a reading assessment, an educational psychologist assessment, a speech and language assessment, an intelligence assessment, a PT assessment, and the parents look at this and go, what is this? What is this? And these are bright parents, and they just don't know. So we say, somebody has to take control. Somebody has to be responsible for guiding, I should have said, this is to do with the teaching and the participant learning. They accommodate each other. But the movement coach, somebody's got to be responsible for the organisation and delivery of a program. They've got to argue the case, plan of action, negotiate with significant others, coordinate with families. It's usually in England either a PT or an OT or the special needs coordinator in school. But it's got to be part of their job. We got the idea from Canada. We've never seen it anywhere else, but they got the idea. We have something like this called a key worker, but it's not quite the same. In Canada, in one part of Canada, they have, for adults with learning difficulties, they have a person called the navigator. I quite like that. You help them. This is for adults who are going into semi-independent living. They navigate their way through the system. And so that's what our movement coach does. The next thing, the movement coach also starts to organize the context and does all of these good things, looks at the commitment of people, looks at scheduling and practice, communication, timetable for action. Don't worry about that too much. But it's whether or not you really need to move, or is there some things that come about through movement. But it starts to look at all of these things. So this is what the movement coach is doing all the time, and coordinating that kind of action. So some of this is quite controversial. It doesn't look it, but we work with functional tasks. We work absolutely with functional tasks. We don't do stuff on underlying processes such as proprioception. We don't do passive movements, and because we're teaching teachers how to do this, and they're not really qualified to do that kind of stuff. But we teach functional movements. We teach movements that are realistic and relevant, everyday activities, formal and informal. We teach active movement. We would always say, teach an active movement wherever possible. So we don't do much guidance of a cerebral palsic hand. We don't do much of that at all. What we do is say, try and reach and grasp something, and if it's all over the place, we sometimes guide it a little bit. But those of you who are students and those who are faculty will know that if I'm reaching to grasp something, I have two or three pieces of information. And one of them is the afferent feedback coming back from the movement, which you get whether it's passive or active. The other is vision, which you get whether it's passive or active. But the third one is the efferent output that you only get on active movements. And you build up that internal model of the afferent and efferent and afferent, and you get that nice model that gives you that discrepancy between the two, that way you can work on that kind of feedback. And you just don't get that with passive movements. You know, you're not really, well, you may get a little, but you're not getting much. So we deal with that. We do realistic and relevant stuff, and the only way I can do that is to give you an example. I have this lovely video of a young man in California. In California, they ride motorbikes, big Harleys, and they don't wear helmets, or they didn't used to. They fall off their motorbikes and get brain damage. And along with brain damage, there's something called apraxia. And apraxia says that it's not dyspraxia, it's apraxia. It means a loss of, so that there's something between the left and right hemisphere that says, I can understand what you're saying, and I can do the movement you're asking me to do, but I can't put them together. And so this lovely video of this young man who sat with a therapist at a table, and she says, I'd like you to wave. Can you wave? Of course I can wave. When do you wave? I wave when I say goodbye, so I'll wave then. And he can't do it. He just does not do it at all. So it's as though there's something stopping that transmission across the corpus callosum on all the various pathways it can be, that is stopping that transmission. So she says, tell you what, stand up. So she says, can you do this? And so she does this, imitation of gesture. And he says, yeah. And there's a kind of a twitching of the shoulder, but it doesn't happen. And then, so they carry on doing something else, and 5 minutes later he says, well, I've got to go now, bye. Goodbye. And so it's because that is contextual. You know, it's realistic and relevant. That's when you do it. Whereas the other ones, he had to abstract and construct an abstraction of that reality, and he clearly couldn't do that because of the brain damage. So we always talk about meaningful actions that are meaningful to the child. And that's I always say, hey, if meaningful actions can overcome known brain damage, they've got to be powerful. And that's a really nice, I think, a very nice kind of example of that. We choose functional activities. We choose specific tasks according to needs, such as handwriting and buttoning. I'm going to flick through a lot of these. But we also need to be able to generalize. You know, we just haven't enough time to teach every movement. So you've got to teach children how to generalize movements on that. So we then go to looking at how to teach specific skills. And those of you who have been involved in this, we know we do analyzing, which breaking down tasks into smaller components, obviously. We adapt the situation, we look at strengths and weakness. We talk about expert scaffolding, what aid that the teacher or therapist gives. And task adaptation is mainly for participation. So you adapt the task, you change the rules of the game, you make a bigger ball, smaller game, a smaller environment to play in, or a larger environment to play in. So you're getting more participation by doing that. We break them down, it's mainly for learning. Together they interact and achieve both learning by participation and learning. So task analysis, we break it down into component parts to make each component is achievable, a whole in itself for motivation, and that you can build them back into the overall task. And this is a course I run for 10 weeks, by the way, so we're going through this in 10 minutes, so I'm sorry about that. But and so, this is our bike riding, this is about 10 stages of our 30 stages we have in bike riding. We have great success in these. These are kids who have failed to ride a bike. So standing on left, holding the bike, braking to verbal command, steering in and out of cones, you're just holding the bike. With brakes, getting on and off the bike, scooting. So we take the pedals off, take the seat off, or lower the seat, and they walk with the bike like this, going in and out of the braking, with a handling belt, put it round them, doing all these things again, etc., etc. It's classic what we do. We have great success with 8 to 12-year-olds who fail to ride a bike on this. And in the UK at the moment, bike riding rules. It's just phenomenally popular. So any 12 or 13-year-old who can't ride a bike is really socially disadvantaged. Absolutely. You lose friends and the whole thing on that. Task adaptation, I've talked a little bit about this, how you change the context, modify the balls, adapt the game. And again, I haven't really time to go into that, but that's what we do. But teaching specific skills is not enough. We have to teach generalization, and it's how prior learning affects new learning. I worked in a center in Los Angeles where we had the young people, and one of the things we did, we took them out to a fitness center, and these were all kiddies with severe learning difficulties, moderate to severe Down syndrome kiddies, and they all did their basketball and swimming, and then they came to get a Coke, and they said the Coke machine doesn't work. David, the Coke machine, I go to the Coke machine, I put my whatever it was in it, and I go, it works. But the display on it was different to the display in the institution where they were. And I can't remember whether the display went horizontal and the other one went vertically, but clearly the signs were all there, but they couldn't transfer that display from where they had learnt it in the institute to in real life. So we've got to be able to do that with kiddies, and this is nearly a golden rule. A lack of spontaneous generalization is often a core characteristic of kiddies with motor problems. Anne Brown, a very famous American psychologist, called it, the kids are welded to the situation in which it's learned. They're just absolutely rigid in that situation. And there are two things you need to generalize. You need to know the task, but then you need to recognize that that situation over there demands this of me. And that's really hard. It's that second bit that's hard. That's really hard. The first bit, you might learn the skill, but you've learned it, and then you can't do anything with it because you can't recognize that that situation needs that from me. So we go back to our little thing. Do we deal with the learner? Do we deal with the context? Do we deal with the task? And we deal with all three. So what do we talk on? Do we change the task? Do we change the learner? And we do all of these things in generalization. Again, these are big programs, so I'm not going to bore you with the detail on this, but we do spend a lot of time on how to teach generalization. There'll be a range of people here who are good and bad at generalization. Some of you are very flexible and fluid and go, and others are a bit more rigid and have more boundaries around your knowledge bases on that. So it's not just kiddies with difficulties. Handling the learning process. We think there are a number of stages the child goes through, understanding the skill, acquiring the skill, automating the skill, generalizing the skills. And these things change at each level. How you give. If you think that learning is all about what the therapist, this is really crude, but therapists give instructions, demonstrations, types of practice and feedback. That's what we do. I mean, that's a fairly reductionist program, but if you wanted to real specifics, there's, we do all kinds of things like make motivation and make feel-good factors, but that's what we do. We give instructions, we give demonstrations, we give types of practice, and we give feedback. And it changes to where you are. Understanding the skill. So the instruction says, pay attention to one thing. And that's where the skill of the teacher or the therapist comes in. What is that one thing you're trying to give to that child at the very beginning to get him into the skill? If you can't get him into the skill, they ain't going to learn it. So that's where the skill of the therapist and the teacher comes in. If you're, I'm sure there are coaches in this room. I coach tennis. If you're coaching a serving tennis, what is the one thing you say to that child? When the first thing you do with a child when you're serving. That's a rhetorical question. I don't want any to tell me that. But, it's very similar. It's no different to that. And I have to talk to coaches about why don't they work with kids with difficulties and do the same with kids with lower ability. They say, well, I don't know how to do that. Of course you do. You do that every day. That's what you do. You're very good at that. We then monitor and evaluation. We check to see if the child's enjoying it, what progress is happening. Do we realign the targets? We evaluate the whole program. So, that is what we've been doing with our programs over the last 50. This is how we set up. I accept this is a lot of information to collect, and it's expensive to collect if you just employ single individuals. So I was just going to talk for the last 5-10 minutes, is that okay, on what we did. We did some work for 4 or 5 years where we looked at 31 children with DCD. So we identified children with movement difficulties, not cerebral palsy. We went into schools and we said to teachers, who are your kids with movement problems? And they gave us about 70. And so then we give them the movement ABC, test, checklist, talk to teachers, pediatricians, and eventually came up with 31 kiddies in the group. We wanted to help. There were long waiting lists. And here was the rub. Physical OTs and others, high skill, low contact time. So you've got a group of very, very good professionals, high skill, low contact time. Others, teachers and parents, unknown skill, potential, high contact time. I'm thinking, hey, surely we can do something about this and get these two lots together. So that's what we did. So we got 31 children aged 7 to 9, initially teachers, and they comply with DSM-4, which is the American Psychiatric Association. They were all diagnosed appropriately with the condition of DCD. And we employed the teachers and parents. And we didn't employ them because we didn't pay them, but we asked them to help. And we had one OT who helped us, who was in our party, but it was myself and Mary Chambers who worked with me on this, provide the program. So these were the questions. Can teachers and parents with help enact an effective program? Can children with DCD be helped in this way? Are there some children who require other forms of intervention? Fairly straightforward questions on this. So we then assessed the children. We did strengths and weaknesses with priorities, exactly the same as I've just gone through on the checklist, on the guidance, each week guidance given to parents and teachers. We gave worksheets, but they weren't, you must do this. They were the priorities and suggested ways of teaching it. And we asked them to do this 3 to 4 times a week, at least half an hour. And we asked them to keep diaries, which they did. They all kept diaries on this. And we gave them things to work on, activities and way to teach on that. And the principles from myself and Sheila Henderson in ecological intervention. So this is what we did. We had assessment of the total group, and it was 7 or 8 weeks, sometimes no intervention, because we wanted to see what happened between this and this when there was no intervention. And nothing happened apart from the kids got worse. So the kids were statistically significant worse. So then we had one group, teacher intervention, group 2, parent intervention. We divided them into 2. We then assessed the total group. We then switched them round. So the ones who were with the teachers went with the parents. Then we assessed them again. Then we had another 7 weeks intervention to see how long it would stay. And we assessed the total group. And that eventually, it says 7 or 8 weeks there, but it took us a year to do this. And we then monitored them for another 2 to 3 years with no intervention. So they basically had a 15, average probably of 15 weeks intervention, about 5 times a week of half an hour duration, which is quite a lot. That would cost an awful lot in your physical therapy service. In fact, it's just not possible in a physical therapy service to give you that kind of detail. So we thought, well, and so we looked at these, all teachers and parents with help. So we monitored and assessed regularly for 2 years. 26 followed through. We lost, I thought we got 28. 14 stayed out of the lowest 5% all the time. In other words, they went from being in the lowest 5% out. 10 stayed out of the lowest 15%. Another eight, some stayed out as long as intervention continued. So as long as you were doing the intervention, they were fine. But as soon as you stopped doing intervention, they crept back into the diagnostic category of DCD. So depending on how you want to measure all of these, 19 of 26 improved as long as intervention is present. And this is why we call it ecological intervention, because if it's a life issue, then there's got to be various people playing various roles. 2 had minor changes, and 2 children stayed in the lowest 5%, no improvement. These kids had 6 sessions a week for 15 weeks and didn't move one jot. So there's a test score over 9. This is over about a 3-year period. This is what a high score is bad. This is the old movement ABC. So a high score is bad. So here they start here, no intervention, and got worse. Intervention, and didn't do much, but then look what happened during the second intervention. And then they stayed like that over the next 2 to 3 years. Anything below 10 is typical development. So this was one of our little stars. We always use this slide. It's a great slide. It's a great slide on that. So that's what happened. And I should say we had more assessments than just the movement ABC. We had interviews with parents, we had interviews with the child, we had interviews with teacher, and they all corroborated this kind of improvement. So then we get another child. So 16, which is puts you well into the lowest 5%. It puts you in the lowest 2 or 3%. That slightly worse, about 17, with no intervention. And then bang, straight down again on the, down again on the first intervention. They improved that much. And then on the second intervention, improved it more, and that's where intervention stopped. And so look what happens. It starts to get back, it does creep back here. But basically, this child is great as long as you keep that intervention going, but as soon as you stop that intervention, things start to happen which were not there before. And then you've got this child this is a child, only moderate problems, but this is a child who this child had 90 sessions. Just over 90 sessions of half an hour each. That's an awful lot of sessions. And you got a bit of improvement, but not much. There's not much happening. So, answer the question, teachers and parents can help and can enact, a program of intervention for children with DCD. They can do it if good OTs, good PTs can give them that kind of help. And it has real implications for how OTs and PTs organise their service in terms of service delivery. A majority of the children can be helped in that way. Some children will need more specific stuff, that it just is not enough this, and you need more specific help. But it leaves you the very expert specialists to concentrate on those kiddies who need that. Our problem is we don't know which ones stay out of the category post-intervention. We can't tell you a priori, and we've looked at every conceivable part of data, whether they were late born, whether they were severe, whether they had co-occurring difficulties, a bit of information on that. That's where we're working at the moment. You know, we've enacted our ecological intervention, and so my final thoughts are that participation is essential for learning to take place. So, you know, you've got to organise that school, that health service, and that community that facilitates kids are welcomed into activities, of motor activities. And not only that, you've got to give them a voice that says, you know, that they're just not there on sufferance, to put it in a dreadful way, but, you know, they are there and they should get enjoyment out of it, and they should be empowered, and they should have a say in what's going on. Little and often, and the amount of practice is the major variable. You know, you've got to do it little and often, and sometimes it might not be a very specific practice. It might be just something happening informally in the home. Can you set the table? You know, these things you've got to organise and do all kinds of things. Clever use of professionals and significant others. You know, how do you use professionals and parents and teachers to their best advantage? A child's difficulties rarely, if ever, reside solely in the child. Yeah. To say it resides in the child is just not on to do that. Yes, they don't, because we have so many different outcomes for children with the same difficulties. You know, you have children with exactly the same difficulties, and you put them in a different situation, and you have different outcomes. And so much of our definition, particular intervention, is in our control. So it's an optimistic model. I'm not saying we can deal with every child. What I am saying is we can really affect some children's lives and you know, engineer the environment for participation and deliver good teaching on that. I've been talking about children, but our recent work, we've been looking at young adults. We've been looking at young adults, and when young adults, when they get to the age of 17 in England, what do they want to do? They want to drive. Do you want to be on the same road as these guys? And so we've got all kinds of information on these people. They can now dress themselves, they can now write, they can now get themselves organised. They take longer to pass their test, they take more tests, they fail more tests, they take more driving lessons. They don't drive as much. They don't drive as much. They drive about a quarter of the miles as other people. And they don't drink and drive, they don't take drugs. They say things like, I'm bad enough without doing that. And they don't have moving accidents. What they do is they hit gateposts all the time. But they don't have major accidents. And Amanda Kirby in Wales has been doing some wonderful work on this with kiddies, you know, because that's what you want to do. So, and it starts to then not become just a motor problem, it becomes a whole social being problem. If you can't drive, or you're really poor at driving, you don't go out as much, you don't socialise as much, you stay at home with your parents more, etc., etc. So it does have more far-reaching effects than that. And these are some of the people who have helped me and, well, more than helped me, carried me through the various studies that I've done. Thank you very much.
For questions, what we'll do is when a question is asked, if you repeat the question.
Sure. So
does anyone want to start?
Yes.
I'll get the ball rolling. My question is about the movement ABC, and if you can compare that a little bit for me to the Peabody or maybe the GMSM.
The GMSM is the gross motor.
Yeah, the generalized motor function.
Yes. Okay, well, first of all, you're asking what the difference is between the movement ABC, which we put out. First of all, you have to be qualified to use it. So only teachers can't use it at the moment. We have argued for teachers to use it, but they won't let us. Pearson won't let us do that. So you have to be trained to use it. The second thing is the movement ABC is very good at looking at that lowest 5, 10, 15, 20% of children. When you get higher up the scale, it's not as accurate. In other words, you know, it is a test of motor impairment. You know, we're not really bothered about you if you're at the 65th percentile or the 80th percentile. And things like the Brunings is much better for that. But the movement ABC is, apart from in the States, it's used worldwide, as you know, for any diagnostic testing of kids with motor impairment on that. And it starts at 3 years of age and goes to 16, where some of them start earlier and go to 6. So we go from 3 to 16 on this in 3 age bands, 3 to 6, 7 to 11, 7 to 10, 11 to 16. So it is different to those, and it's different to the gross motor, of course, because it includes, you know, 3 areas. One is fine motor ability, the other is balance and agility, and the other is ball skills. We get a lot of argument from some cultures about ball skills, but in England, in Western Europe, in Australia, in Canada, and USA, ball skills are important. You know, in that 7 to 11, you know, they're important. In other countries, they're not. So we say, well, if you don't want to use that part of the test, don't do it. You know, but you know, we normed it on that. So, and if you take any factor analytic studies of motor abilities, you'll find the ball skills, aiming and catching, balance and agility, and manual dexterity come out as either factors or clusters. You know, that's it. We don't do strength in it. There's no strength and no endurance in it. So we're really looking at skill learning rather than maximum performance on strength and endurance. Yes.
You said you had some further work to do about predicting an outcome, and I didn't catch that sentence.
The question is, we had some further work to do about predicting outcomes. At the moment, we have these 3 kinds of outcomes. There are those that stay out of the category, those that stay out of the category as long as you're doing intervention, and a small proportion who don't move. I'm saying we don't have any way at the moment of predicting a priori which those kiddies are. And so that's why we have ecological intervention. So we are now going back into the data to see whether or not there's anything in the data, on the masses of data we've got on these kids, that can give us an indication that some of these children that gave us clues as to what the outcomes would be. At the moment, we just haven't got that kind of thing. So that's why we're saying, you know, if you're serious about this is intervention, you know, over a long time period. That doesn't mean to say, oh, you're coming home and you must do half an hour. It's not that at all. It's that clever use of lots of individuals, whether you're a parent, a brother or sister. I'm going to play cards with you. I'm going to do this with you. Just incidental things in daily life that we do, as well as the more specialist stuff that a therapist will tell you to do. And we're advocating that the therapist then talks to the family about the daily activities you can just put in front of the child. It's not practice, it's experience. I differentiate between experience and practice in so much that practice is a more formal form of experience, whereas experience says, I'm coming across it in daily life. So that's why we advocate this ecological intervention where, you know, where things happen all the time. I'm not claiming this is perfect, and this is hard work. You know, this is hard work, and so you've got to be convinced that this is going to make your child's life or the person's life better. But certainly the 2 activities of 11-year-olds that I talk today about with people today about, that we are of paramount importance to 11-year-olds in the UK system, is they've got to be able to write fairly quickly and legibly in secondary schools, or you get left behind. You can't take homework from the board, you can't listen to what the teacher's instructions are, so you've got to be able to write fairly quickly and legibly and read your own writing, one thing. And secondly, it's really advantageous to ride a bike in your social activities. So that has happened over the last, we've always been a bike riding community, but you know, ever since the Olympics and we started getting big gold medals, despite the fact these people who get gold medals have thighs like my chest, you know, and you know, they're not the same animals as we are. It is popular, you know, they're becoming as popular as the soccer players, and so the kids want to be like it, and so now the bikes are there all the time, and there's clubs, etc., that for youngsters, and so it is really important to be able to ride a bike now. On that, yes, Anne.
Can you talk a little bit more about generalization? So is that by changing the environment, have them interact in the environment? Is it more cognitive that you try to help them make a transition of analyzing the situation, or is it both?
Well, generalization. Anne's asking what I mean by generalization. It's taking a skill and using it in a different situation or modifying the skill slightly to accommodate a particular demand. And we try to do all of those things. First of all, we teach, many of you might be familiar with a very old motor learning theory called schema learning. And I don't know if people, some of you, where it says in order to learn something, you don't just practice that same thing, that basketball from there, you practice from different shots. You have variability of practice. So we break down the tasks, first of all, into classes of events. So I will have a class of events that says, I'm going to do reaching and grasping, but I'm going to do it in 10 different ways. Or I'm going to do manipulation, and so I take my watch, I can't do it, I haven't got a pen with me, but if I take my watch, I can do things like this. I can just move it up and down like that. I can put it in my fingers and move it up and down. I can start to twist it round. That is and so I got lots. So what I do, I give variable practice on a range of skills within a class of events. So we do that, first of all, on the tasks. So that's really changing the task. We then do exactly what you say in terms of cognition. We use a lot of the activities that people like Helen Politico use on their co-op practice that says, that talks about self-monitoring, goal setting, self-assessment, where the child cognitively looks at the task and verbalizes what that task demands of them. And then we change, and then we look at the context in which it's set. So I've always maintained that anybody who can really find the key to generalization will make a fortune. It is one of the most difficult things to teach a child, or any of us. When, I don't know how many of you ski. The first time you go on skis, and you've got these things on your feet, and you go, what have I done in my previous life that is going to help me now? And it's not a lot. But you then try and find something to hang your hat on, and that's generalization. My wife is Californian, so she was a surfer, which is not quite the same, but there's a few things in there, and those of you who are tennis players and you come to badminton. Okay, there's a thing flying through the air, but one is a more arm movement, one is a more wrist movement. So you've got various things like that you're trying to, and it is difficult. We're much better at teaching specific skills than we are at teaching generalization, but we've got to teach it. You've got to teach that because you just haven't enough time in the world to teach the whole set of skills that a child will need from experience. And if you've got a child who hasn't got movement problems, they're usually not experiencing as many varied situations as a typically developing child. We've just done some work down in Wales on 3 to 5-year-olds, where we have different levels of intervention. So I'm locked into intervention these days. I still do a bit of experimental work.
Any further questions?
First I should make my disclaimer. I'm here as a parent.
Okay.
Which by default has made me a practitioner.
Fine.
Occupational therapy, among other things. And recently I was introduced to something called neurological reorganization. And I'm wondering if you have any familiarity with that. And it's occupational therapy basics, considering the losses that many children, particularly adopted children, lose in those early years, and creating particular therapies around those losses, like eye movement, and I'm trying to think of other sort of basic skills, like reading is perhaps connected to those eye movements that you get as a child when you're in the crib looking for your caregiver, or mathematical skills of going up and down, what you learn when you're doing your early standing skills, which if you're left in a crib, those things aren't encountered. So I'm just learning about it. I'm very curious about it. I think it applies to my particular situation. I'm wondering if it's something that enters into your field, or if you have any thoughts on it.
We teach functional skills because this is highly specialized work. So we don't do that. That's been around for a number of years. 50, 60 years. It's been around, and it's come under various guises that you basically are reorganizing the neural system. It's fascinating. The evidence is not great.
Oh,
The evidence is not great, but it's absolutely not going to do any harm. It's going to be, and in some instances we have. When I say the evidence is not great, we have empirical studies on that says, as a group, it doesn't seem to be any different from any other way of doing it. But there are individuals within that group who will benefit from it. But we have no idea of knowing which individual. That's the key, you see. And so, and because it's highly specialized stuff, we leave it alone. You know, I'm teaching parents and teachers to do stuff, and that's why we deal with functional skills. The idea behind that is that if you get the neural stuff right, you automatically get generalization, because you're teaching underlying processes that may affect a group of skills. That is the idea behind it, that you are, that there's something wrong neurologically, and if you can, and if you can remedy that, then you're not just dealing with hand skills, you might deal with eye movements, and you might deal with a whole lot of other things. The problem is, it is really difficult to get empirical data on that. I mean, like, just virtually impossible. And so we've left it alone. I mean, I ought to tell you, it's a very controversial batch of literature. And if you want to email me, and people can give you my email, I will send you some references on it. Yeah. So,
one connection I did see is, and I thought rang very true for me, was when you spoke about doing something regularly and going to an occupational, and what this preaches is you do
all the time,
every
yeah.
day. And I think that makes a difference in so many things.
Okay, but I can play tiddlywinks with a child, and I might get some improvement. You know, regularly is not a method of improvement, it's a manner of delivery. And so, you know, so it's the method, you know, I'm not arguing against it. I'm just saying that every method ought to be doing little and often and regularly, ought to be, whatever method you're using. We know that is better than doing one big block session. We do know that. We've got just a stack of motor learning literature on that. It just tells you about distributed practice. You get into a definition as to what is distributed, but that's another issue on that. But if you know, it is a highly there's a sorry, I'm spending a lot of time. There's a highly controversial worldwide company called the Door Company, which has been putting this neurological reorganization out, and that's in Europe and Australia and UK. They've just gone out of business, but they did do a lot of work, and there's been highly controversial. And the reason I'm being so circumspect is that a couple of academics had a go at it in terms of criticizing it, and so the proponents of them took them to court. And so, you know, you're dealing in basic money. And so, you know, so it is a controversial area. It's not going to do any harm. The evidence for it is not great, but it will be okay for some kids.
This comment, the neural reorganization is the issue. I mean, it's really the transfer, right?
Yes.
But what is much more known now than back certainly in the 60s, 70s is just how plastic.
The blade is plastic.
So that's the, I mean, to do it repetitively, I mean, we know that encourages the brain to regroup. Maybe not in exactly the same way as the organization.
Absolutely. Yeah.
There are some aspects are very well supported.
Oh, absolutely. It's when people start doing a lot of stuff for big money, when people get a bit suspicious on things.
Okay. So